In this video, we will talk about the normal ECG and common abnormalities. Sinus rhythm refers to the heart rhythms when the heart is activated by an impulse from the sinoatrial, also called sinus, node. It's a normal rhythm. However, non-sustained rhythms that originate from parts of the heart other than the sinus node can be observed in perfectly healthy individuals. These rhythms are considered normal variants. Normal sinus rhythm means that P waves occur at a rate of 60 to 100 beats per minute with less than 10% variation in the PP interval. Each P wave is followed by a QRS. If the heart rate is less than 60 beats per minute and P waves precede each QRS complex, sinus bradycardia is present. For example, this ECG shows regular sinus rhythm with a heart rate of 48 beats per minute. If the heart rate exceeds 100 beats per minute and P waves precede each QRS complex, sinus tachycardia is diagnosed. For example, this ECG shows a regular sinus rhythm with a heart rate of 122 beats per minute. Sinus arrhythmia is characterized by irregular PP intervals resulting in an irregular ventricular rhythm. Variation is greater than 10%. Often, the PP intervals gradually shorten and lengthen depending on the phases of the respiratory cycle. In such cases, respiratory sinus arrhythmia is diagnosed. The P wave represents atrial depolarization. The initial part of the P wave corresponds to right atrial depolarization, the final part to left atrial depolarization. The middle part of the P wave represents both right and left atrial depolarization. Normally, each P wave has the same morphology and is positive in leads 1, 2, 3, and AVF. The normal duration of the P wave is less than 0.12 seconds. The P wave amplitude should not exceed 2.5 mm in the Lin leads and 1.5 mm in the precordial leads. A wandering atrial pacemaker is one of the most common rhythm abnormalities. In this case, there is a gradual change in the morphology of the P wave. At least 3 different morphologies are required to diagnose this condition. Typically, there are positive, negative, and intermediate morphologies of the P waves. If each P wave is inverted, or negative, in leads 2, 3 and AVF, an impulse originates from the lower parts of the atria or the atrioventricular node. If the PR interval is less than 120 milliseconds, the impulse is considered to originate from the atrioventricular junction. This is called junctional rhythm. If the PR interval is 120 milliseconds or longer, the rhythm originates from the atria. This is called ectopic atrial rhythm. In this case, there are only 1 or 2 different P wave morphologies. Ectopic atrial rhythm should also be suspected if the P wave in lead 1 is inverted, but this condition should be carefully distinguished from incorrect lead placement. Multifocal atrial tachycardia is diagnosed when at least 3 different P wave morphologies are present, the rhythm is irregular, and the heart rate exceeds 100 beats per minute. There are 4 different P wave morphologies on this ECG. Absence of P waves combined with irregularity of QRS complexes in tiny waves caused by disorganized atrial activity, also called F waves, are characteristic features of atrial fibrillation. There is no clear P wave in this ECG. However, there are tiny F waves with variable amplitude and rate. Sometimes organized atrial activity can be seen, but at a very high frequency. In this case, there are frequent F waves and irregular or regular QRS complexes. This is atrial flutter. P waves may be absent in the escape rhythm. A junctional escape rhythm is characterized by the absence of the P wave and narrow, regular QRS complexes. However, inverted P waves may precede or follow QRS complexes with a PR interval of less than 120 milliseconds. In this case, the P wave is superimposed on the ST segment or T wave. The idioventricular rhythm originates from the myocardium of the ventricles. It is an escape rhythm and is characterized by broad QRS complexes. P waves are absent or follow the QRS complexes. Normally, each P wave should be followed by a QRS complex. When some P waves are not followed by QRS complexes, there is abnormal conduction from the atria to the ventricles. This condition is called atrioventricular block or heart block. A premature P wave followed by a QRS complex is called a premature atrial complex, supraventricular extrasystal. Its shape is typically markedly different from either of the P waves of sinus origin. A high P wave with an acute apex is called a peaked P wave. such a P-wave amplitude exceeds 2.5 mm in the limb leads. Typically, this refers to leads 2, 3 and AVF where the P-wave amplitude is higher. Such P-waves are seen in right atrial enlargement. Because this condition is often seen in pulmonary diseases, such P-wave is called P pulmonale. A wide P-wave with duration of more than 0.12 seconds that is bifid in lead 2 and biphasic in lead V1 is characteristic of left atrial enlargement. In this case, a terminal portion in lead V1 is negative and has an amplitude of 1 mm and a duration of 0.04 second. There are many causes of this condition, but these P-wave abnormalities are most prominent in mitral stenosis. Thus, such a P-wave is called P mitral. A bifid P-wave may also be seen in the left precordial leads. The PR interval reflects the atrioventricular conduction. It's measured from the beginning of the P-wave to the first deflection of the QRS complex, Q-wave or R-wave. The duration of the PR interval is measured similarly to the RR interval. The normal PR interval ranges from 0.12 to 0.2 seconds. If the PR interval is prolonged and constant, first-degree atrioventricular block is diagnosed. If the PR interval is longer than 0.3 seconds, atrioventricular block of the first degree is diagnosed. Progressive prolongation of the PR interval followed by a non-conducted P-wave, absence of the QRS complex after the P-wave, is characteristic of type 1, also called Mobitz 1, second-degree atrioventricular block. Type 2 second-degree atrioventricular block is distinguished from type 1 by intermittent non-conducted P-waves without progressive prolongation of the PR interval. If every second P-wave is not followed by a QRS complex, second-degree atrioventricular block, type 2:1, is diagnosed. If every third, fourth, or fifth P-wave is not followed by a QRS complex, high-degree, or advanced, atrioventricular block is diagnosed. This is sometimes called fixed ratio block because there is a fixed P-QRS ratio, 3:1, 4:1, 5:1. The absence of a relationship between P-waves and QRS complexes is called third-degree atrioventricular block. It's also called complete heart block. No atrial impulse is transmitted to the ventricles. QRS complexes may be wide, distal atrioventricular block, or narrow, proximal atrioventricular block. PR intervals are variable. A short PR interval, less than 120 milliseconds, means that the ventricles are depolarizing prematurely. This condition is called pre-excitation. There is an accessory pathway that connects the atria to the ventricles. The accessory pathway conducts an impulse faster than the physiological pathway, which includes the atrioventricular node. Short PR interval, wide QRS complex, more than 120 milliseconds, and delta wave, slurred upstroke of the QRS complex, are characteristic features of Wolff-Parkinson-White (WPW) syndrome. Negative delta waves may be seen in some leads. They may be misinterpreted as pathological Q waves. The combination of short PR interval, absence of delta wave, and normal QRS complex width is characteristic of Langenau-Levine (LGL) syndrome. Some authors believe that this syndrome should be diagnosed only in combination with the ECG pattern in paroxysmal supraventricular tachycardia. The QRS complex represents ventricular depolarization. It consists of three waves, Q wave, R wave, and S wave. There may also be two or more R waves and S waves. There are many features of the QRS complex that should be considered. First, the width of the QRS complex should be measured. A normal QRS width is less than 100 milliseconds. Sometimes a QRS width of 100 to 120 milliseconds can be found in healthy individuals. Narrow QRS complexes are supraventricular in origin. Complexes originate from the sinus node, atria, or AV node. Wide QRS complexes are either ventricular in origin or supraventricular in origin with intraventricular conduction abnormalities. A QRS complex width more than 100 milliseconds is considered abnormal. A QRS complex width greater than 120 milliseconds is required for the diagnosis of bundle branch block or ventricular rhythm. The most common causes of wide QRS complexes include left or right bundle branch block, including rate-dependent conduction abnormalities, ventricular pacing, Wolff-Parkinson-White syndrome, hyperkalemia, sodium channel blockers. ventricular ectopy, ventricular extrasystoles, ventricular tachycardia, ventricular escape rhythm or complexes. Hypothermia. Left bundle branch block produces broad, notched waves with absence of Q waves in leads V5 V6, EVL and dominant S wave in lead V1. Right bundle branch block produces M-shaped complex and dominant R wave in lead V1 and deep slurred S wave in leads V5 V6, 1, AVL. Incomplete, or partial, right bundle branch block is characterized by RSR pattern in lead V1 and QRS complex width less than 120 milliseconds. WPW syndrome produces a wide QRS complex with delta wave and short PR interval. If the pacing spike precedes each wide QRS complex, the rhythm is ventricular pacing. Hyperkalemia produces high symmetrically peaked T waves, wide bizarre QRS complexes, wide and flat P waves, conduction abnormalities, sinus bradycardia, or atrial fibrillation with slow ventricular rate, sinus pattern. Sodium channel blockers, such as type IA and IC antiarrhythmics, tricyclic antidepressants, cause wide QRS complexes in positive R and AVR. A premature broad QRS complex without a preceding P wave is called a ventricular extrasystole. Sometimes a premature broad QRS complex is preceded by a P wave, often abnormal. This condition is called an aberrant conduction supraventricular extrasystole. A rhythm faster than 100 beats per minute consisting of 3 or more consecutive ventricular beats is called ventricular tachycardia. It may be sustained or non-sustained, depending on whether it lasts less than 30 seconds or more. If there are wide QRS complexes at a rate of less than 50 beats per minute with regular RR intervals, an idioventricular rhythm is diagnosed. The absence of P waves before QRS complexes is also required. An abnormal T wave and discordant ST segment displacement are seen. Accelerated idioventricular rhythm is characterized by regular wide QRS complexes at a rate between 50 and 100 beats per minute and the absence of P waves. In hypothermia, Osborn waves, also called J waves, are seen. The Osborn wave is a positive deflection at the end of the QRS complex. It's most prominent in the precordial leads. The Osborn wave may be negative in leads AVR and V1. Other ECG abnormalities seen in hypothermia include bradyarrhythmias and prolonged PR and QT intervals. Shivering artifacts may be seen. The Q wave represents depolarization of the ventricular septum. Normally, the Q wave should be small in amplitude and width. Physiological Q waves are typically seen in leads 1, AVL, and V5, V6. Q waves are usually absent in leads V1, V2, V3. Pathologic Q waves are generally indicative of myocardial infarction. They are observed in the acute phase and typically persist. Pathologic Q waves are often the only sign of previous myocardial infarction. According to the 4 universal definitions of myocardial infarction, a Q wave is considered pathological if its width is not less than 0.03 second and not less than 1 mm deep in any 2 contiguous lead groups, 1, IVL, from V4 to V6, 2, 3, IVF. Any Q wave in leads V2, V3 with width more than 0.02 second is considered pathological. QS complex in leads 1, 2, 3, AVL, AVF, from V2 to V6 is pathological. Negative, also called inverted, T waves in leads with pathological Q waves support the diagnosis of myocardial infarction. Posterior myocardial infarction produces a higher wave with a width more than 0.04 second in leads V1, V2. The R wave amplitude exceeds the S wave amplitude, dominant R wave, in leads V1, V2 in the absence of conduction abnormalities or pre-excitation. Dominant R wave in lead V1 is observed in healthy children, right ventricular hypertrophy, right bundle branch block, WPW syndrome, dextrocardia, muscular dystrophy, and improper precordial lead placement. Dominant R wave in lead AVR is observed in the following cases: incorrect limb lead placement, dextrocardia, and use of sodium channel blockers. In the presence of wide QRS complex tachycardia, the dominant R wave in lead AVR indicates its ventricular origin. This ECG is recorded when the left/right arm leads are reversed. There are inverted P waves, negative QRS complex, and inverted T wave in lead 1. Also, there is dominant R wave in lead AVR. Compare with a normal ECG in the same patients when lead placement is correct. The R wave progression in the precordial lead should always be evaluated. Normally, the R wave amplitude in lead V3 should be greater than 3 mm. Anterior myocardial infarction, lead misplacement, dextrocardia, mediastinal shift, pectus excavatum, left ventricular hypertrophy, and dilated cardiomyopathy may result in poor R wave progression. It's important to look at the QRS complex voltage. Low QRS complex voltage occurs when the amplitudes of all QRS complexes in the limb leads are less than 5 mm or the amplitudes of all QRS complexes in the precordial leads are less than 10 mm. This may be seen in the following conditions: pericardial effusion, obesity, emphysema, amyloidosis, dilated cardiomyopathy, and massive myocardial infarction. This ECG shows a low QRS voltage. The highest amplitude of the QRS complex in the limb leads is 4 mm in lead 2. Increased R wave amplitude in leads 1, AVL, V4, V6 and increased S wave in leads 3, AVF, V1, V3 are characteristic features of left ventricular hypertrophy. The most common criteria are Sokolov-Lyon criterion, S wave depth in lead V1 plus R wave height in lead V5 or V6, whichever is higher, more than 35 mm, R wave in AVL more than 11 mm, R wave in lead 1 plus S wave in lead 3 greater than 25 mm, Cornell criterion, R wave in lead AVL plus S wave in lead V3 more than 28 mm, R wave height in lead V5 V6 greater than 25 mm. These indices are called voltage criteria because they are influenced only by the amplitude of the R and S waves. However, in fit and thin young individuals, higher waves in leads V5 V6 are often seen and considered normal. This is a good example of when the ECG should be interpreted according to the clinical context. This ECG shows very high amplitude in the precordial leads. In the precordial leads, the QRS complexes of a certain lead merge with the QRS complexes of the adjacent leads. The Sokolov-Lyon criterion is 48 mm. Other ECG changes supporting left ventricular hypertrophy are left axis deviation, SA segment depression and T-wave inversion in leads 1, AVL, V5, V6, called left ventricular strain, and signs of left atrial enlargement. All criteria for left ventricular hypertrophy have low sensitivity and high specificity. In other words, they may not be met if left ventricular hypertrophy is present. ECG can help diagnose right ventricular hypertrophy. Right ventricular hypertrophy results in a dominant R wave in lead V1, i.e., R wave height exceeds S wave depth, a dominant, persistent S wave in leads V5, V6, i.e., S wave depth exceeds R wave height, and right axis deviation. Signs of right atrial enlargement, right ventricular strain, IST segment depression and or T-wave inversion in leads V1, V3, 2, 3, IVF, support right ventricular hypertrophy. Right ventricular hypertrophy often results in right bundle branch block, in which case supporting ECG changes, such as right atrial enlargement and right ventricular strain, are suggestive of right ventricular hypertrophy. This ECG is recorded in a patient with right ventricular hypertrophy and left bundle branch block. Note the right axis deviation, the dominant R wave in leads V1 through V3, and the depressed S wave in lead V6. Sometimes tremor can almost completely prevent ECG interpretation. This ECG was recorded in a patient with Parkinsonism. Tremor can significantly affect the quality of the ECG recording. In general, when a patient is relaxed and warm, the quality of the ECG is good. However, some patients have a permanent resting tremor, e.g. essential tremor, Parkinson's tremor. In this case, the quality of the ECG is poor, but it can be partially interpreted. Tremor artifacts are seen as regular or irregular deflections on the isoline. The ISC segment is the portion of the ECG between the end of the QRS complex, called the J point, and the beginning of the T wave. It represents the interval between ventricular depolarization and repolarization. There are many causes of SC segment abnormalities, but the most common are myocardial infarction and myocardial ischemia. Normally, the ST segment is isoelectric, at the level of the electrical conduction system. However, slight elevation or depression may be seen in perfectly healthy individuals. According to the fourth universal definition of myocardial infarction, there are distinct features that suggest acute myocardial ischemia, ST segment elevation at the J point in two contiguous leads not less than 1 mm in all leads except leads V2 V3. ST segment elevation is considered pathological if it is not less than 2 mm in leads V2 V3 in men older than 40 years of age, or greater than or equal to 2.5 mm in men younger than 40 years of age, or not less than 1.5 mm in women. Also, horizontal and downsloping ST segment depression not less than 0.5 mm in two contiguous leads is considered pathological. An upsloping ST segment depression has a significantly lower value in the diagnosis of myocardial ischemia. If it occurs during exercise testing, the result is considered equivocal. The upsloping ST segment depression is observed in 10 to 20% of healthy subjects. Also, it may be found in patients with the myocardial ischemia. Benign early repolarization produces ST segment elevation similar to that seen in myocardial infarction. However, benign early repolarization is characterized by upward concavity of the ST segment and the initial part of the T wave. A notched or slurred J point is also observed in some leads. The T wave is high and slightly asymmetric with a straighter and steeper descending limb than the ascending limb. ST segment elevation is most common in precordial leads from V2 to V5. The notched J point, called the fishhook pattern, is most prominent in leads V4 V5. Pericarditis produces widespread ST segment elevation with PR segment depression. The T wave represents ventricular repolarization. The normal T wave is positive in all leads except AVR and V1. T wave inversion in leads 3 and AVL may be seen in healthy subjects. However, new-onset T-wave inversion in these leads is pathological. The highest T-wave amplitude is seen in leads V2 and V3. Normally, the shape of the T-wave is asymmetric with the descending limb being straighter and steeper than the ascending limb. The T-wave amplitude should not exceed 5 mm in the limb leads and 10 mm in the precordial leads, although agreement of the T-wave amplitude with the QRS complex amplitude is important. A T-wave inversion, also called a negative T-wave, is considered when its depth exceeds 1 mm. The most common cause of T-wave inversion is myocardial ischemia. Sometimes T-wave inversion may be the only permanent sign of prior myocardial infarction, if pathological Q waves were not formed. Left ventricular hypertrophy can cause left ventricular strain, which includes ST segment depression and T-wave inversion in leads I, AVL, V5, V6. Other causes of T-wave inversion include pulmonary embolism, hypertrophic cardiomyopathy, intracranial hemorrhage, and WPW syndrome. It's also secondary to bundle branch block in leads with a prominent R wave. Peak T waves are seen in hyperkalemia. Similar T waves, called hyperacute T waves, may be seen in the early stages of myocardial infarction. They may precede the development of ST segment elevation and pathologic Q waves. Biphasic T waves may be seen in myocardial ischemia or hypokalemia. Biphasic T waves in leads V2 V3 are seen in Wellens syndrome resulting from left anterior descending artery lesion. Bifid T waves, called camel hump, are seen in hypokalemia because of prominent U waves or as a result of superimposition of the P wave on the T wave. Bifid T waves may also be considered a normal variant in children when seen in the precordial leads. Flat T waves are seen in hypokalemia, seen as widespread T wave flattening, and myocardial ischemia, seen as T wave flattening in the contiguous leads. The QT interval is the time between the beginning of the QRS complex and the end of the T wave. It represents the time required for ventricular depolarization and repolarization. The QT interval is measured in lead 2 or alternatively in leads 1 and V5. It can be difficult to define the end of the T wave because the last one can gradually merge with the isoline or the U wave can merge with the T wave. There are two methods to define it, the maximum slope intercept method, also called the tangent method, and the threshold method, when the end of the T wave is determined by the point where the T wave merges with the isoelectric baseline. The maximum slope intercept method is preferred in most cases. The QT interval changes with heart rate. Faster heart rate leads to a shortening of the QT interval. Slower heart rate results in the lengthening QT interval. The QT interval can be corrected for heart rate using many formulas. Bazette's formula is the most commonly used. It divides the QT interval by the square root of the RR interval in seconds. It may overestimate the QT interval at a high heart rate. A prolonged QTc interval is of great clinical significance. Congenital long QT syndrome is a rare inherited disease caused by genetic abnormalities. Electrolyte abnormalities such as hypokalemia, hypomagnesemia, and hypocalcemia can cause prolongation of the QT interval. Many medications can cause prolongation of the QT interval. These include antiarrhythmics, e.g. amiodarone, dronedarone, sotalol, antidepressants, e.g. citalopram, acetylopram, bupropion, mianserin, amitriptyline, imipramine, doxepin, nortriptyline, antipsychotics, e.g. haloperidol, droperidol, olanzapine, quetiapine, chlorpromazine, antimalarials, such as chloroquine, hydroxychloroquine, antibiotics, such as macrolides, fluoroquinolones, antihistamines, such as estimazole, loratadine. Other causes of prolonged QT interval include myocardial ischemia and increased intracranial pressure. It can be found after cardiac arrest. Normally, the QTc interval ranges from 350 milliseconds to 440 milliseconds in men and from 350 milliseconds to 460 milliseconds in women. A prolonged QTc interval of more than 500 milliseconds is associated with polymorphic ventricular tachycardia, called torsade de pointes. In general, two drugs that prolong the QT interval should not be prescribed at the same time. However, if it's necessary, close monitoring of the QT interval will be done. Short QTc interval can be caused by hypercalcemia and digoxin use. Congenital short QT syndrome is an inherited cardiac channelopathy associated with sudden cardiac death primarily due to ventricular fibrillation. It's diagnosed when the QTc is less than 350 milliseconds. Thank you for watching this video. Please like and subscribe.